Case presentation. The case I present here is female, 52 years old. The diagnosis is adult congenital scoliosis. Past history. She had a hemivertebrectomy for thoracic hemivertebra at the age of 13 years. At the age of 50 years, she visited a private orthopedic clinic complaining of low back pain and left leg pain with coronal malalignment. Her lumbar scoliosis was 44 degrees with a convex to the left and L4 tilted 27 degrees to the left at that time. MRI showed fused vertebrae of L2 and 3 with mild kyphosis and disc degeneration. At that clinic, myelography was performed and demonstrated hypermobility on L4 and 5. She had canal stenosis at L4-5, becoming more severe with active extension. Myelographic images also show that she seems to have lumbar kyphoscoliosis with anterior segmentation defect at L2 and 3. After these evaluations, she was surgically treated by performing PLIF from L3 to the sacrum. You can see that the coronal alignment postoperatively aggravated to the left as shown in this slide. When she visited my clinic at the age of 52 years, actually this was 2 years after previous surgery, she complained of unbearable low back pain with difficulty in standing for longer than 5 minutes. She showed coronal malalignment with 5 cm to the left, and C7 plumb line fell down ahead of the hip axis. She had double major scoliosis with thoracic curve 42 degrees and lumbar curves 46 degrees. L4 tilt angle was 29 degrees, and this seems to be a main cause of coronal malalignment. In order to evaluate whether she had canal and foraminal stenosis, we performed myelography followed by CAT scan. You can recognize solid diffusion to the lower lumbar spine with sacral tilt of 29 degrees and the existence of multiple vertebral anomalies from upper thoracic to the sacrum. Now, based on these findings, I ask you how you treat this patient. I'm sure almost all spine surgeons here agree to surgery. The question is, what is your strategy for this patient? Because time is limited, so at first let me show you what I've done for this patient. After my presentation, I would like to have your opinion. I performed unilateral PSO of the right side of L5. Through this procedure, I could correct L4 tilt from 29 degrees to 13 degrees as shown in this slide. I added the bilateral iliac screws for secure lower anchors at the time of correction and stabilization. Fusion level were the same as the previous surgery and did not extend fusion to the upper lumbar or thoracic spine to correct kyphosis. Postoperatively, her lumbar scoliosis improved to 30 degrees with acceptable global alignment. Discussion. When we look back the reasons why this patient required revision surgery, I think there are 2 reasons. First, the surgeon who performed the first surgery focused on correcting the main lumbar curve without paying attention to the pattern of coronal alignment. Second, the difference in stiffness between the lumbar and fractional lumbosacral curves due to sacral tilt actually induced postoperative coronal malalignment. Obey to emphasize coronal malalignment should be carefully evaluated when performing adult spine deformity surgery. They also classified coronal malalignment into two types and suggested a treatment algorithm for coronal malalignment in adult spine deformity surgery. For type 1 coronal malalignment, correction should be obtained at the apex of the main curve. For type 2 coronal malalignment, correction should be obtained at the lumbosacral junction. Regarding to the surgical method, Cham presented a symmetrical PS wall for coronal imbalance treated surgically in 14 patients. He could achieve excellent restoration of coronal imbalance. However, the complication rate were high, 64.3% of patients. In this last slide, I will show you what I have learned through this experience of this patient. Coronal and sagittal malalignment tend to deteriorate ADL of the patients. Easy approach such as PLIF for correction of lumbar curves, in particular coronal malalignment type 2, without any approach to the sacral tilt, deteriorate coronal alignment and did not improve the pathological condition at all. Whole spine X-ray images should be always reviewed at strategic planning. Special attention should be paid to the sacral tilt, including fractional lumbosacral curves, when considering surgical strategy in patients with coronal and sagittal imbalance. Correction of malalignment can satisfactorily relieve low back pain. Osteotomy is very effective for correction of global malalignment in patients with congenital scoliosis. When performing lumbosacral fixation, the placement of at least 4 anchor points on both the proximal and the distal segments is extremely important for correction and stabilization. Thank you for your attention.
So our two lecturers are not available for the question and answer portion. So these two are recorded. Yes, yun nga.